Hi there. Today I want to talk about trauma-informed care versus dissociation-informed care. So trauma-informed care is really a way of approaching people, where we assume that all people have faced adversity and that adversity is going to make them respond to certain stressors or certain cues in their environment in certain ways. And if we can be thoughtful about that, we can make the world a much gentler place for all of us to be. Dissociation-informed care, though, requires additional knowledge, assessment, and clinical decision making. Trauma-informed care, though, is not necessarily the same, as I mentioned, as dissociation-informed care, even though they can sometimes be used interchangeably. Trauma-informed care gives us an essential foundation, which is safety, transparency, predictability, choice, collaboration, empowerment, cultural humility, and an awareness that behavior often makes sense in the context of what somebody has survived. I would say dissociation-informed care is kind of built on that premise. That's the foundation for what's next. A trauma-informed provider may understand fight, flight, freeze, attachment disruption, hypervigilance, avoidance, and nervous system activation, but still miss significant signs of dissociation. So dissociation requires us to ask different questions, not only what happened to you, but also how did your mind organize itself around what happened? Trauma-informed care often assumes we are working with one relatively continuous sense of self who's carrying or responding to trauma. Dissociation-informed care recognizes that traumatic adaptation can involve compartmentalization of memory, emotion, bodily experiences, behavior, awareness, and identity. And this changes assessment. A dissociation-informed clinician actively assesses for dissociative symptoms rather than waiting for a client to spontaneously report them. We have to inquire. And people often do not know that what they experience is dissociation. They may describe losing time, finding evidence of things they don't remember doing. They might describe feeling unreal, feeling the world is unreal, and they might describe internal conversations or conflict. They might describe changes in skills or preferences or feeling younger without having language to describe what is happening. Dissociation-informed assessment can mean being curious about parts, internal life, and internal organization, and being able to ask these questions in a way that normalizes this. We all have parts of self. It's integrated into our day-to-day language. A part of me feels this way, a part of me feels that way. We know about dissonance and the discomfort it creates inside of us. This is just an adaptation, and the adaptation is proportionate to what happened in the past. So if we can approach it through a lens of normalization, it can also help address shame and stigma and also fear around these symptoms. It means dissociation-informed assessment means being curious about the internal life of the person sitting in front of us and being unafraid to ask the questions. Observable behavior matters too. So you might notice some clearing gestures. We might see this, hands going like this, some hiding behaviors where, someone might want to shield what they perceive as parts of themselves being overtly obvious. Typically, it is not overt, it's quite subtle. However, that is not the experience of the client. So look for things that you can see that might be subtle and ask about them. Other indicators might be blank staring or temporary unresponsiveness, shifts in eye movements, shifts in posture, and shifts in appearance. So they're not diagnostic by themselves. The point is that dissociation-informed clinician notices them, becomes curious, and assesses rather than immediately labeling them as avoidance, resistance, noncompliance, manipulation, lack of motivation, or sometimes psychosis. And this distinction is important. It affects the way we pace the work. Dissociation is automatically going to indicate that we need to move a little slower, not just in how we approach our care, but also how we approach our assessment. So a trauma-informed clinician is going to encourage emotional processing at some point in the work. And yes, a dissociation-informed clinician is also going to promote emotional processing or trauma processing at a certain point, usually in the second stage. However, the length of time spent in stage one, in that early work of skill building and building relationship, is much longer for people who are experiencing dissociation, because this is a clue that their system, their nervous system, is saying, hold on a second, we need to pump the brakes. This is too much. Because these are conditions of protection. They're conditions of hiding what is too much or too overwhelming to be known or to be experienced at any given point in time. And our job is to really honor that. So it does really affect the pacing. And also with structural dissociation, one part of the person may be genuinely ready to talk about things, including trauma, while other parts experience the therapy itself as pretty risky. So both realities can exist at the same time. And this is why apparent resistance needs to be approached differently. What looks like avoidance may be protection. What looks like inconsistency may reflect compartmentalization, and what looks like regression may represent a shift in self-state. Dissociation-informed care pays attention to the internal system, not only the presenting symptom. So we're looking at both. The therapist relationship can also be experienced differently across self-states. So making it permissible to talk about that in the room can bring a lot of relief and safety. For example, one part might trust the therapist, another doesn't. One may remember the session clearly, while another has limited memory of what occurred. This means that predictability within the therapeutic relationship becomes especially important. You want to explain what you're doing, why you're doing it, and in what order. Knowing what to expect protects against unnecessary surprises and prepares clients for unavoidable uncertainty. And also consistency matters. We want to be on time, we want to be orderly, structured, and clear. We don't need to be perfect, but we need to do our best, and that's the framework that we utilize in treatment. I like to organize my sessions in thirds in addition to the overarching treatment trajectory. So, the beginning is getting settled in, the middle is the harder work, and the end is closing up and making sure our clients are comfortable when they leave. And making sure you have adequate time for that last piece is very important. So also boundaries matter. I would even change the word boundaries to parameters. Every relationship has parameters. And as long as it's clear and consistent without being cold or punitive, they're part of establishing safety. They're very important. And also it helps the therapist maintain the relationship and make sure it's sustainable, because it has to work for both parties, just like any relationship. So being very clear and consistent around your relational parameters is very important. Humility matters too. If you don't understand something, acknowledge it. It's okay. If you don't know enough about dissociation, say so and seek consultation and training. And also cultural humility belongs here as well. Dissociation does not exist outside of culture. There are studies that have identified the fact that structural dissociation exists everywhere. Perhaps how it's interpreted or experienced is different from one culture to the next, and we want to make room for that in our work, of course. But we don't want to assume that it doesn't exist because we're somewhere else, or it does exist because we're somewhere else, if that makes sense. So continue to stay curious about the meaning of experiences rather than forcing every internal experience onto a single explanatory framework. So you can be an excellent trauma therapist and still need additional training or education about dissociation. This isn't an insult at all to trauma-informed care. Again, that is foundational to what's next. It's an acknowledgement that dissociation is a specialized area of knowledge, and that more people knowing about it is just a good thing. And the goal, though, is not for every therapist to become a DID specialist. The goal is for more therapists to recognize dissociation, assess for it, understand how it reflects pacing and treatment, and know when consultation is needed, and referral, of course. So, trauma-informed care asks us to understand behavior in the context of what happened to someone. Dissociation-informed care asks us also to understand how the mind adapted, compartmentalized, protected, and organized itself around what happened. So if we're treating trauma without actively assessing for dissociation, maybe consider what might be missed. Thank you so much, and I hope that this was helpful. I'll see you soon.